All right. Well, good morning, everyone. Thanks for being here this morning. Super great treat for us to have Dr. Cheng with us this morning and talk to us about a topic that I think we're undereducated on, but research into health policy and payment for spine surgery. So super excited to have you. Nikita, did you want to say a few words before we got going?
Thanks, Dr. Mundis. Thanks, Dr. Cheng. It's a huge honor to have you. Dr. Cheng is the Frank H. Mayfield Chair of Neurosurgery at the University of Cincinnati. He did his training initially in neurological surgery back at the Medical College of Wisconsin, and where he also did a spine fellowship. He was on faculty at Vanderbilt for many years, where I met him as an undergraduate student, actually, before joining the faculty at Yale, and now at Cincinnati. He's an internationally renowned neurosurgeon, an expert in numerous topics, including socioeconomics, and has been a leader in our specialty, including the AANS, as well as the AO spine and CSNS. He's a phenomenal educator, amazing person, and thank you so much for taking the time to join us.
Thanks, Nikita. Thanks, Nikita. Thanks, Greg, and for inviting me, and thanks, Mike, for setting everything up. So, the topic I was going to talk about is really, when we talk about socioeconomics, it's really about health policy. And I think one of the things that I'm trying to get people to understand in our field is really how our research and our publications and work impact how we get paid. And it's not as straightforward as you would think. And I'm just kind of, hopefully explain some of this and in the next 25 minutes as we try to get through this topic. Nothing to disclose. So my journey to health policy, I started off like everybody else with a complex spine fellowship, right? I thought I knew about biomaterials, understanding yield strength of rods, fixing a lot of cases, as many of you were coming out into the complex spine area. Most of our work is actually fixing problems from other surgeries. Cases like this one to the left, with the cervical case, this is just what we do, and we feel pretty comfortable about what we do and what we know. So, but as I got into this, what I realized is sometimes how we view our cases are different than how the people around us, like the hospital administration. So, for example, this is a case that had 8 surgeries by one of our community deformity surgeons when I was down in Nashville, who then subsequently couldn't stand up and breathe at the same time. After he, had these complications, 2 free flaps that didn't take, sent over to the university emergency room because, he needed a higher level of care. So I took him to surgery after a 2-stage procedure or 3-stage procedure, 2 weeks in the ICU. He was up and walking. This is a picture of him in rehab telling me, "Thank you, I got my life back." So you can imagine, in my mind, I was like, wow, I'm pretty cool. I get to do these big corrections and fix things. And it was amazing when my administrator wanted to chat with me about this. I thought it was probably to give me an award or maybe want to do a press release about the cases we can do at Vanderbilt that they couldn't do in a community to correct. Unfortunately, it was the other way around. What they were concerned about was that this patient had already exhausted their lifetime insurance policy, were pending Medicaid, and that the hospital is already $300,000 in the hole from this patient's care with a potential risk of not being compensated for that. The other thing is that they looked at my practice, and because I did a lot of revisions like this, they didn't understand the difference in spine surgeons. So compared to other spine surgeons who did more elective cases or degen disease, I had a higher blood loss, higher length of stay, more ICU management, and basically they were concerned about my quality and whether or not I needed to talk to some of my other partners about additional training, because my patients just seemed to be sicker than what they did, and most of their cases went home the same day as outpatient. So you can imagine that to me, it was a bit of a surprise, and also realizing that, wow, from a hospital standpoint, I thought I was a pretty high value surgeon doing complex cases like this, but my hospital system looked at me as a low value surgeon because my costs were pretty high. So the denominator, my value, my blood loss, amount of transfusions, all the metrics that they typically collect made it look like I was actually doing a pretty terrible job taking care of people compared to those doing MIST lifts and others that were able to get their patients out and get paid a lot for their procedures. The other thing is that, so that kind of made me start thinking about health policy. The other thing is that, as of most of us, we thought coming out of training, we're going to be physician scientists. So I ran a Vanderbilt biomechanics lab. This is just a picture of my first and only R01 funding back in 2006, 2005 was when we got it. Looking at biomechanics of spine, we I did a lot of spine research looking at basically the idea was force over, the area under the curve of a force deformation curve is really energy, right? It's a first order integration. And so the whole point about this was when we started talking about artificial discs. I remember talking to Earl Fender at the time, who was the worldwide president, and Rich Taselli, who was a spine surgeon from North Carolina, who was their chief medical officer, about how motion preservation did make a lot of sense because things don't fail by motion; they fail by excess energy, excess kinetic energy. Hence, traumatic injuries, as we're aware of. So I thought it was pretty smart when it comes to this. And then we did a lot of research on, basically spinal biomechanics and really how to maintain appropriate loading with motion preservation, but also force preservation within that. I actually, because of that work, got involved in helping develop the first lumbar arthroplasty CPT code for the AMA. And that's how I got involved in the whole CPT process back then, was with the work that I did with the our artificial joints at that time. And the lumbar artificial discs actually has a lot of good literature, a lot of good level one literature. And if appropriately applied based on the patient's expected biomechanics, it actually had really decent results. And that's why even currently, both number of societies that we have, for example, NAS, ISAS, et cetera, have position statements and guidelines and really pair policy suggestions saying that it should be covered since it does have a benefit to patients based on the literature that we have. But if you look at the Medicare data set and insurance company pair policies through something called Policy Reporter, what you realize is that no one's really still getting paid for this. Lumbar arthroplasty, despite 20 years of research, is still considered investigational without a medical necessity. And if you look at the claims data for Medicare, what you realize is that most surgeons aren't doing it in billing for arthroplasty, at least through the Medicare or standard insurance contract. And they were probably billing it, what we call shadow billing or hybrid billing, where they're billing like an artificial disc with a lumbar fusion just so they can mask the artificial disc component. And so the question is, wow, how do we go from really solid data that supports the use of technologies that we have in spine to no one's paying for it, and surgeons are driven away from using the technology because, well, they're not going to be compensated for doing that? Well, it's the same reason why I had to disclose, right? I kind of glossed over this, but I don't really have any financial relationship. I'm not a consultant. I don't really do that because of my health policy requirements for being in that space. But I did get an honorarium over 2 years ago, which doesn't count anymore for most disclosures. The question is, why do we have to disclose and why do we have the Sunshine Act? And I think it's one of these things where if we were in person, I'd be polling the audience about how much do you think you get paid for lumbar hardware? Like how much do you think a surgeon gets paid to put in 12 pedicle screws compared to 4 pedicle screws, right? And a lot of people, when I ask that question, they think I get paid with $1,000, maybe $500 a screw, $100 per screw. The irony is that we actually don't get paid to put in hardware. And in fact, if you look at the CPT coding, once you do a T12 to L5 pedicle screw fixation versus L4-5, the surgeons are really getting paid after the first 4 screws. You're getting paid roughly 16 cents a screw. So if you think about it, not only are you getting paid 16 cents a screw, once you start asking for additional costs like navigation, O-arm, and the robot, you're looking at your workflow. What most surgeons don't realize is that to put in your hardware, you're actually getting paid less than minimum wage to do this. So you can imagine that because of this component, senators like Senator Grassley back then in early 2005 and to 6 started asking questions like, we talk about papers like the rape of the spine, about how much there's too much metal going in, too much hardware. Surgeons aren't getting paid to put in hardware. In fact, they're underpaying them to put in hardware, yet they keep putting in more hardware. The only people making money are the companies that get paid $700 a screw, $50 a cap, $650,000 for an O-arm or navigation system, etc. And so they had this perception that physicians aren't dumb. Surgeons aren't going to work for free. We all want to make money in our jobs. So there must be some under the table payments that they're not aware of that are part of the stark violation for this. And so that's why we have things like the Sunshine Act and why we have to report, is because outside of our field of surgery, a lot of people don't understand why surgeons do what they do. And I would suspect that most residents, most of the people listening on here probably didn't realize how much you got paid for your surgeries or how you got paid for your surgeries. And that gets into the whole idea of social economics and why sometimes we get frustrated with some of these rules that don't make sense when in reality they do. So, for example, another rule that doesn't make sense is the never event. So, Medicare says you can't have spine surgery infections, kind of like large joint infections for orthopedics. And you're like, well, why do they do that? We have meta-analysis and review papers looking at literature across the history of spine surgery, and there's never, except for a few, one-off papers, no one's ever reported a 0% infection rate for any of our surgical areas. And we know that the incidence not only is not going to be zero, it actually varies based on the type of patient. So if you have a trauma patient with a dirty wound from an open compound fracture, someone with acute discitis that already comes in with a spine infection, you have a high chance of contaminating it further. Metastatic tumor with radiation, you get the picture. Even when Ziego Coslin presented some of his studies on his tumor patients, even with the en-bloc corpectomies, I remember some of his infection rates were 14 to 17% because you have a very hostile environment. And then certainly if you do MIS approach in a healthy patient that really had no other comorbidities, the infection rate is going to drop down to 0.5%. It's not going to be zero because people still get infected overall. The problem is this. If you look at the way infections are treated outside of surgeons, people look at us and say, well, wow, surgeons are not incentivized to actually take care of infections. In fact, they're getting paid more to take someone for an IUD because there's a perception that just IND of a wound, a deep spinal infection, is an easier surgery than, say, doing a de novo lumbar discectomy. And the issue is that you actually get paid a little bit more for a work unit than you do for a de novo lumbar discectomy or kyphoplasty. You get the picture. Like, if we didn't think kyphoplasties were worthwhile at 7.99 RVUs to do on a regular basis, why do we think spine infections are there? So they started thinking about, well, what happens if we stop paying surgeons and made it bundled payments to see if we can prevent them from doing unnecessary infections? Like they're not motivated to prevent infections because they get paid anyway if it happens, a complication. So they tried this across the board. And they tried it both in total joints and spine. And I just put that picture on the bottom left just to highlight relative to total joints. Spine is just still a drop in a bucket for overall, the incidence and the total patients that are affected by that. But it didn't really work. They actually sunsetted the quality reporting system because what happens is that doctors, when you're getting penalized like this, you just stop taking care of those patients. If someone's going to say, I'm going to make you take care of this homeless alcoholic who has a high risk of infection, your first answer is like, well, I don't want to take care of them. And we call it patient selection. So, when we hear comments of people saying, well, if you wouldn't have dinner with that patient, you probably don't want to do surgery on that patient. We think it makes a lot of sense for patient selection. The problem is that those patients don't have a lot of other options. And, Medicare and the health insurance companies see that as well. And they know that trying to penalize patients or penalize physicians, for things like complications doesn't really do well because we'll just avoid those complications and patients then are denied care overall. So they took it a little bit different way. This is a paper from Hopkins that was based on the early Medicare assessments. And really what they kind of started thinking about was, what if we targeted the employers? More and more physicians are becoming hospital employed. So if we start changing how hospitals are paid by eliminating SSI, I wonder if that would help. And so this is a paper. This is a paper that the chart shows that for adult spinal fusions and really for large joints and orthopedics, that if you can eliminate or decrease infections, hospitals would lose a lot of money. And so the idea is that, wow, you know, given this, these are two target areas that we can do for hospital-acquired conditions that if we actually told the hospital systems we're not going to pay you for them, they're going to be highly motivated to do that. Unlike things like coronary artery bypass grafts, where if the hospital eliminates infections, they'll actually make even more money compared to fusions. And so because of this, they started looking at this as far as areas of targeting for doing that. Hence the Federal Register. The final rule on June 30th, 2011 was published, adding in things like spine infections to the list of never events or never pay events for Medicare. Ironically, well, I shouldn't say ironically, in reality, Medicare and some of the health policymakers were right because this publication was the first publication that actually changed the incidence of reporting of CPT code 22015 for IND of deep spinal infections. So all the papers we've written up until this point, talking about how to manage infections and strategies for doing it, didn't change the prevalence of the needing for IND of inspections, but just telling hospitals we're not going to pay you for IND of infections all of a sudden made the numbers start going down. So it did work. And so that's why CMS has really adopted these things called never events. There's really three types of never events if you look at CMS and the National Equality Forum. And really CMS's policy, and this is back in 2008, was really developing this process to motivate hospitals to accelerate improvement. And so that they wouldn't pay the comorbidities or the higher MSDRGs. So hospitals potentially would lose a lot of money by having infections in the spine, for example, for these never event profiles. So there's three types of never events, and I'll just kind of highlight them. There are true never events that are not paid for. For example, surgery on the wrong patient, surgery on the wrong body part. No one's going to pay you for an unnecessary surgery. So that's pretty clear. And both the National Quality Forum and CMS agree with that. There's also never events the hospitals do get paid for that really should not happen either. For example, postoperative death in a healthy patient. Patient comes in for a lumbar discectomy, complication happens with a vascular injury, they die. The hospital will still get reimbursed for that care unless they chose to write it off themselves. But like I said, but it's something that shouldn't happen either, right? So this is that list. But the third list that's a lot more controversial is what we call no pay events. These are things that aren't quite never events, but the hospitals won't get paid. If you ever, and I don't know about your hospital, but most hospitals, there's a focus on CAUTI, CLABSI, catheter-associated urinary tract infections, central line infections, and then really also surgical site infections from orthopedic procedures, spine, neck, shoulder, elbow. And so the hospitals really focus on this because it doesn't come across as as a newsworthy, terrible new article. So, for example, you're not going to highlight we kill less patients with elective surgeries than other hospitals, but people are not afraid of admitting that we have central line infections and we're going to do a lot of work on this. And the same thing with surgical site infections overall. So this has been going on for some time where hospitals are not getting paid. The issue is that over the last 10 years, since the policy went into effect in 2011, the infection rate has dropped, but stayed around roughly 6.7% compared to all spinal surgeries. And Nikita knows, like when you do data mining through the large data sets that we look at, we see these types of trends. So we know that infections aren't going to be zero. So you may ask yourself, well, hospitals are already being penalized for spine infections. We know we're never going to get to zero. You have people with tumors, trauma. Why can't we just say 6.7% is the acceptable rate and set the bar a little higher and saying if you keep your infection rate less than 7%, you're doing pretty good. So if you have a patient with diabetes with a hemoglobin of A1C of 9.8, but is going paralyzed with cervical myelopathy and needs a cervical laminectomy infusion, can we say that patient deserves surgery knowing that we're going to have an infection post-op, a higher likelihood because of that situation? So the problem is that the answer is no, because HACs are not based on data that shows the incidents that we're talking about. The hospital-acquired events is really based on the Deficit Reduction Act that was signed into law back in 2005. So the short answer is, looking at this data, the hospital-acquired conditions aren't going to be changed by how many publications we show of this. This becomes lobbying efforts to be able to change policy in order to do that. And that's that transition that I kind of mentioned overall. And so the impact of never events are pretty significant. If you look at how DRGs or hospitals are paid, you're talking about taking a patient that would be a margin for the hospital that is worthwhile taking a patient into a huge loss leader overall. And not only that, depending on how your hospital collects. So for example, the difference between a spinal deformity surgery that you may do that has no comorbidities, your average length of stay is expected to be 3.0. So this is from Medicare's data set from table 5. And so you're talking about a big spinal deformity going home in 3 days. Well, that's what they expect with no comorbidities. But if the patient has comorbidities like congestive heart failure, pulmonary edema, other things, all of a sudden your length of stay expected to be 10.6. Well, if you're not getting credited for the higher DRG or the CCs or MCCs, that is the comorbidities, they're going to look at you and says, "We are a terrible doctor. Your length of stay is terrible. It's double what it should be, and you should be getting the patients out the door." And then the physicians are frustrated because they're like, "This is impossible. The patient needs to be here for these reasons." But it's that disconnect between the health policy assessment versus what the physicians are doing, in your practice. Well, why else can we do this? Well, it's because insurance fundamentally has a different model than care, and you know this. So I use United Healthcare as an example, and I don't condone murder or any thing violent, but but the insurance companies, do tweak us quite a bit. United Health Insurance policy, their stock's been dropping. This is just a picture when they dropped $130 in a day, and a lot of it has to do with their model. Make a long story short, part of their model, and this is their revenue. Part of their model is something called float. So we did a ad hoc analysis in our coding and reimbursement committee. Make a long story short, if you read their 10K SEC report based on short-term interest rates, by denying surgery 2 weeks, they make an estimated $1.4 billion in float. That is the money made off of the interest rates on short-term interest without paying out that payment or premium. So if you think about it, what's the data that physical therapy before spine surgery improves care or does improve care? Well, what you realize is that 80% are the denied cases are going to get approved, and over 90% in some areas, especially in spine, get approved. So you're like, you're going to approve it anyway after I appeal. Why do you want to put us through this whole process of medical directors and peer-to-peers? It makes no sense. Well, if you're getting 1.4 billion for denying surgeries for 2 weeks and then approving it 2 weeks later, what you realize is that you could spend up $400 million in health and medical directors to deny surgeries. Actually, I take that back. You can spend $1 billion in medical directors to deny surgeries for 2 weeks and finally make them jump through hoops and approve it and still make a $400 million profit. So you understand that this is the business aspect of healthcare that sometimes we get caught in. And the issue is that we talk about medical care ratio, SGA, and we don't have the time for me to go through all this, but it's a totally different model. The challenge is this. If you look at healthcare in general, if we just took away the dividends and in the sense of insurance companies making a profit, it doesn't get counted against healthcare, but it's paid out using the premium dollars that are collected from patients overall. What I'm trying to say is that the shareholders of United Healthcare made more money than all of neurosurgery and all of spine combined. So that if you say, I don't want to change a single decision in healthcare, how can I save a few $1 billion without affecting anything we do? It's like, just don't pay a dividend, just don't make a profit for an insurance company. The problem is that we're in a capitalistic society, so it's really hard to say things like that. But it's also one of the reasons we can't seem to fix the problem, because we can't address the problem directly, the root cause, based on our, the fundamentals of the society we live in overall. So this is the challenge. How do they get us to agree that we need to get them more profit and do less medical care? It's because they tell us we have bad quality. And I think this is where quality is used to regulate behavior. The problem is that defining quality in medicine is pretty tough. I put this up there because that's how most of us define quality. The problem is that there's so much controversy. So if you're saying quality is safe surgery or safe medical care, so many studies about untrustworthy clinical trials, so that we get to pick and choose the trials we do. Everything from steroid management to spinal cord injury. I mean, you got it, right? Head trauma for concussions. Even controversies in equity. This is SI fusions. Even if you look at Dave Pauly's paper, and if you look at the current Medicare data set 27279, is sacroiliitis and sacral joint dysfunction, is it really a Caucasian disease where 92% of all patients having SI fusions are white and no other racial profile? So the question is, how do we answer things like this so that even just our inclusion and exclusion criteria is just literally, this is Medicare data set of what we do overall. The other irony is, if you notice, for SI fusions, most of it's actually being done by pain management overall. And so the other thing is that we also talk about scope of practice. And while we're fighting among surgeons, the pain doctors are doing over 52% of that, and actually is the fastest growing lumbar fusion group for things like the Minutemen and other procedures. And that's a whole different discussion overall about health policy. And then there's also controversies in effective care, and the problem is that we muddy our own waters. So instead of calling things a T-lift because we're not going to get paid by Medicare for the laminectomy and decompression codes and osteotomies, we're now calling them intradiscal osteotomies. And so when we muddy up the water in medicine and our research, it really gets hard to kind of define who's doing what and what exactly are we doing, which is why we're having challenges. So for deformities, we have some prominent orthopedic spine surgeons that were used to be part of societies that are working for medical insurance companies that are bringing up osteotomies, calling them overvalued codes. So right now, our societies are really trying to address this issue of devaluing our deformity surgeries by we're expecting that if this goes through, spinal deformity surgeries will drop by over 40% in reimbursement, which may not even make it viable to continue performing them for many areas overall. And so that's why I was saying that there's a discordant role of research and access to care. So things like FDA access or approval compared to clinical practice versus how we regulate access with insurance and medical legal. This is something that I think as physicians, we all need to understand of how that falls into place. I'll just use the example of Barricade just because it's, you know, becoming so the barricade. So the issue is this: the research data needed to get a device like this approved really is different across the board, and that's why you have that disconnect. So if you look at the FDA approval data that they have on there, what you realize that this data was statistically significant on their improvement versus controls. But if you look at their, what they did was that they had a 73% failure rate in the control group for large defects, but the failure rate for Barricade was not that much lower at 53%, but yet was statistically significant to do that. The problem is that even though this is data that's good enough to get through the FDA approval process, now you get to the next step, which is CPT coding. So CPT has its own rules for research and how data is used overall. And so there's a lot of studies for that. The problem is that the studies were all based on using Barricade as a device after lumbar discectomy. So by definition, it was not a standalone device and had to be looked at as an add-on code for discectomy, which opens up other challenges overall. So the literature that's used for CPT coding is different than that, and therefore it was accepted in September 2024, which will be published in January 2026. The other thing is that because of the length of time it takes to develop coding paradigms and payment policies, the lead time, of 2 years typically for someone to do that, most surgeons are like pretty immediate. They want something to be paid tomorrow, not 2 years from now overall. The problem is that the insurance policies and how they look at literature and how they do it are different as well. So basically, because of the fact that most of the papers show that it did not appear to affect patient-reported outcomes or reoperation rates, which is what they care about. Did it lower cost? Does putting in this device lower costs for the patient population of lumbar discectomies? Then the answer is no. Then they really don't care about symptomatic reherniation. They care about, did the patient go back to surgery, and did we have to pay more to that justified the use of that device? So that's why I'm saying that across the board, you notice that these papers that are needed to kind of, I guess, uh, support a thing or process. And then that gets into a different issue, which is how the hospitals are paid. So because the way Medicare rules are with annual closure devices, so basically in the outpatient setting, HOPD or ASC, you're not going to get paid more than a primary code. The problem is that once you use a device for a primary code that typically does not have a high cost, you're not going to get enough. And this gets into something called C codes, which I won't get into overall. So to kind of summarize, insurance companies don't use a lot of data to regulate. Medical legal standard of care is a legal definition. It has nothing to do with literature support, all that. And yet we start off with evidence-based medicine, which is why, in summary, it becomes a little bit more frustrating overall. So it's 9:30, so hopefully I finished just in time for Let's Talk. But thanks for your time and your attention. Thank you very much.
It's a deep
Wowzers.
topic.
I just felt like I looked under the trunk. Didn't like what I saw. Like that's
You
not
saw
good.
how the sausage
I
was
saw, oh my gosh, saw a bunch of dead bodies in the trunk. It's not good.
Yeah, it's a lot of information, but it's not something that we typically talk about in fellowship or residency training,
Well, we have a lot of trainees here, Joe. Like, what is maybe some things that you can encourage us on and how we conduct ourselves and the research we do, et cetera. Like, are there, what would be heavy on your mind to share with a group of young people as they enter this world? And,
Yeah,
you know,
that's a great
yeah,
question. My suggestion is we need more physician administrators, and I think we need surgeons, especially in our field, to really take on the helm of understanding some of this because that's who drives it. So, when we get frustrated with these decisions, if we get people, and that's why a lot more surgeons are getting MBAs and other things, and I encourage that because I think we need to get into these roles of making decisions. The other thing is that even if you do research, you need to kind of think about what's your target for your research. Is it research for the sake of research? That is, are you just publishing data just because you want to get a paper out? And if that's the end result is get a publication in a journal, that's great. But that's different than saying you have a publication that is going to help provide access to patients or access to care. And that's different. And I think that's where a lot of companies are frustrated because they work with key stakeholders and key opinion leaders that help them get research done, but it isn't targeted. And then everybody gets frustrated when all of a sudden all that work and effort, like for example, if you look at BMP7, there's so many examples in the past of so much money being put into research that just was from the very beginning, you could tell that that methodology was not going to get you very far. And you were going to waste a lot of money on a device development that was just going to end up in a roadblock when it comes to reimbursement.
awesome.
Questions, you guys? Are you too wowed? Wow. Overwhelmed, Joe. They got the Q sign.
Well, good. Well, it was a pleasure to talk to you all. I'm sure that if there's any other questions, I'm look forward to seeing everybody at the next spine meeting so that we can catch up.